Governor Roy Cooper has used emergency powers to shut down North Carolina businesses during the COVID-19 pandemic, and he's instituted all sorts of rules and mandates and prohibitions. But the data upon which the governor based and continues to base his prohibitions is far from clear. In fact, some of it's pretty foggy, as Locke Foundation researchers have been detailing for months now. Jon Sanders is Director of Regulatory Studies for the Locke Foundation. He joins us now with a look at what we know and, importantly, what we still don't know. Jon, welcome back to the show.
Thanks, Donna.
Let's talk first about testing and COVID-19 positive cases. The Department of Health and Human Services has a dashboard on their website, and they keep track of the data. We have periodic news conferences from Dr. Mandy Cohen in which she gives us the numbers. But you have been doing a lot of drilling down into the numbers, looking at research and what other states are doing, and you have determined that there's really discrepancies in how different states are defining what a verified case of COVID-19 is. Help us understand this.
Okay, so that gets to what the predominant way of measuring cases is through something called PCR tests. And essentially what they do is they take a sample from someone and they cycle it to detect strands of viral RNA. And each cycle kind of doubles the amount that they've been able to detect from the first cycle. So think about it as if you're doubling your money. If you've got a little bit of money, but you double it over 16 times, you'll suddenly have a lot of money. So if you come in with a sample and you've got an actual infection and you get it cycled, it doesn't take long to discover, oh yeah, this person has the virus. If you have a scrap of viral RNA, it may take a bunch of cycles before it gets big enough to determine it, doubling and doubling and so on. The problem is the way North Carolina and most other states in the U.S. and many other testing services do these tests is well beyond the research scientific consensus for how many cycles it should take. The scientific consensus is 30. The CDC has looked at it and said they weren't able to find really viable virus beyond 33 cycles. The New York Times wrote an expose on this at the end of August, and their experts suggested no more than 30 to maybe 35.
What is North Carolina using?
North Carolina is using 37, which means we're basically doubling more and more, at least 7 to 10 times what the research consensus is, because some of the tests would use 40.
Does that mean, Jon, can we conclude then that when North Carolina counts someone as a positive case, that it could be that some of those folks really are infected and they've got a lot of virus, but there may be some people in that count who have a very, very low level of virus?
Absolutely. And that's one of the problems with the test. The test itself is not a problem, but what it can tell you is a yes-no answer. Do you have viral material? The more it cycles, the less useful that answer is going to be, because the other thing it's not telling you is how much viral RNA you've got. Do you actually have an infection, or do you have some viral RNA floating around?
One would think, Jon, that states would at least be consistent, since we're comparing, at least in news reporting, we're comparing states against one another for how many cases are active, etc. And the CDC, one would think that states will be following their guidelines. So kind of what gives here?
Well, the states aren't consistent in any of their data on this during this pandemic, which is one of the frustrating things is as a well-meaning researcher and anyone who is just trying to get good information.
Because as I mentioned at the top, of course, Governor Cooper and Dr. Cohen, in consultation with the governor, they are making public policy decisions that are impacting 10 million plus North Carolinians based on this kind of data. At least this is one of several data points that they're using. So it behooves us all. Doesn't matter your ideology, your politics, or anything. It's important that we all understand what those decisions are based on.
Absolutely. And for example, in the New York Times expose, they had a Harvard epidemiologist look at the the cases that they knew of, if they cycled them at 30 as opposed to 40, which is what they were doing in Massachusetts, it would have thrown out 85 to 90% of their positive cases, which is just a shocking amount. In other studies at other states, Nevada, New York State, it was closer to 63%. But still, you're talking about a vast majority of cases that might not actually be infections, which would also explain why we have the phenomena of asymptomatic infections. Maybe it's because they're not really infections. We just don't know, because even in North Carolina, we don't know how many cycles it took to get to that. And some states will have those data, but North Carolina and many other states apparently do not.
John, do we know if Dr. Mandy Cohen or Governor Cooper have been asked about this situation?
I have no idea that they have. I certainly haven't seen any evidence that they've been asked about this, not by media.
Well, it's such a critical question for obvious reasons, and your explanation is really helpful. That leads me to the next question then. One of the other important data points that we follow, and again, that public policy decisions, whether businesses can open or close, whether kids are going back to school or not, is based in part on the number of people who are hospitalized for COVID-19. Is that data accurate?
That's a good question, too. And the DHHS was asked about it. And essentially what they say is they're not making a distinction between someone hospitalized for COVID and someone hospitalized with COVID. For you and I in regular conversation, what you want to know is, has this infection gotten to the point where it's put you in the hospital? That's what we worry about. The way it's done for DHHS is, if you're put into the hospital because of COVID, or if you have gone in for a routine examination, or you've been in a car wreck, or you're having heart palpitations or whatever, they will test you as part of their clinical assessment. And if you test positive, even though that's not why you're there, you will be counted as a hospitalization with COVID.
And then, sadly, of course, we do have people who are succumbing to COVID-19.
Yes.
The death data also reported by DHHS, one of the data points that they look at and base policy decisions on. What do we know about the death rate? Is that accurate? Have those folks that we think have sadly died from COVID-19, is that really the cause?
Yeah, it's very difficult with viruses in general to disaggregate whether it's the virus that caused it, because the virus can set into motion a whole bunch of other things that will lead to death. And that's what we're concerned about. But we can't tell is if someone was hospitalized and died with COVID as opposed to as a result of the COVID infection. And there's no way of knowing from this vantage point how many are in either category. There's just no way of knowing, so I don't know.